Yes, and I'm going to say it this way. It will not be simply because your hemoglobin A1C came down. It's going to be because your insulin levels came down. That's what's going to reduce your risk of heart attacks and future heart problems. Because when you look at the lowering of your hemoglobin A1C, yes, patients with lower hemoglobin A1Cs do have lower heart attack rates. So there's no doubt about it. But it's like the statistics I was showing you before. You get a bigger bang when your insulin resistance gets better. So if you came to me and said, my insulin levels dropped from this much to this much, that's going to tell me that your heart attack risk has gone down more than if you said my A1C came down from this much to this much. So again, there's a hidden entity in the background that's really predicting your cardiovascular risk, and it's your insulin. And how will you know that your insulin sensitivity has come back? Very simple. Look at your stomach. If it's gone, your insulin resistance is better. If your weight has gone down, your insulin resistance is better. So, but of course, you can always measure your insulin levels too. So I urge you all, if you have diabetes and you still look the same, but you're taking a bunch of drugs and your A1C is now 6.0 and you say, I'm so good, my doctor is proud of me, I don't think you did too much. You just made the number look good, but you're still going to get heart disease. But if you come back and say to me, my body mass index has come back to normal, my abdominal girth has gone down, my HDL has gone up, my triglycerides have come down. Now you got my attention. Now your heart risk has gone down. Yeah, it is a contradiction. So what's happening is that here's a man who's already a diabetic, who's on a statin. So then you got to look to say, okay, he's got coronary artery disease. Has his coronary artery disease been stable or has it been unstable, progressive? Has he had recent stents put in him? Has he had a chronology that's showing that 1 year he gets it, then 2 years later he gets another stent? So the fire is on. If the fire is on, if you still have the feeling that this patient is making plaque in his body, his CRP is still high, his ratios are not very good in his lipids, his weight is not perfect, he's got other risk factors that are untreated, maybe he's got sleep apnea that's still untreated, he's going to have a risk. So then, even a small 3% reduction in your risk by use of a statin is probably a good idea. Then you've got to watch for side effects of statins other than that. If he's already got diabetes, then of course you're going to treat the diabetes the way we normally treat diabetes. But in addition, you need to be on what this newfound knowledge is, that you just stay away from all sugars and get your insulin levels way down. We only started doing insulin levels about not even a month ago. So this is very new, to actually measure insulin levels. Insurance companies didn't want to pay for this. So again, you got to look at the overall risk for the patient. That is why sometimes we feel uncomfortable leaving patients on statins. But then we discuss it, and we always ask for side effects. When a patient's on a statin, you ask the following questions. Do your muscles ache a lot? Do you feel like you got the flu with your muscles? When you stand up from a chair, do you have to use the side rails? Can you keep your arms up a lot? No? Then do you feel you're losing a lot of muscle strength? Then you know that he's getting probably a side effect of the statin. Then you look at his sugar. If his sugar levels continue to go higher and higher and higher, you need to say, well, anything I can do to make this better. So you may want to consider that that's a statin side effect. If the patient feels that he's losing his marbles and he's forgetting things, then you say, well, you know what? I can't explain why you're so forgetful now. Perhaps this is a statin side effect. Let's give yourself a statin holiday. So you go by symptoms. And a statin holiday, nothing goes wrong when you give a statin holiday. It's a good thing. So you need to put it to the test sometimes when you just stop the statin for a month and the patient comes back and say, I felt no difference. Okay, then so it's looking at your risk versus benefit ratio. But at least we know now talking about it versus dogma. Dogma is, I don't care, you need to be on a statin, period, end of story. And I think now we're questioning it. So it's just an increasing awareness. It's an increasing awareness. But yeah, so look at your symptoms, become a participant in the decision making. And when you do that, You may come up with more symptoms and come up to me and you'll say, Dr. J, I am feeling those things that I heard about. And then we can look at all the risk factors. See, that's why they call this the art of medicine or the practice of medicine, because there's very little dogma here. It is really a sense of putting things together and coming up with a plan for the patient, knowing the patient in his individuality and lifestyle, putting it all together. Ketones. My thoughts on ketones. I think that we have ketones in our body, and at a certain time in our physiology, we make ketones. And we should, because that's what is an alternative fuel for us. And going into ketogenesis at certain times in our physiology, and day and night, has been a normal part of your teleological evolution. But almost all of us never allow ourselves to go into a ketonic phase, or not sufficiently. And the reason is because we never fast. Remember, your ancestors fast. So after 12 hours, the glycogen stores were all used up, and after about 24 hours, the ketone levels started rising. There was a purpose for that. Ketones were not put in our body to kill us quickly. It was a survival mechanism so that you can survive the fasting phase because you couldn't make a kill that day. Our physiology is still based on Paleolithic times. So ketones, am I against ketones? Absolutely not. Ketones are an alternative fuel and can be used by the brain and all muscular tissues, but there's another added advantage. One is obvious survival because it's an energy source. But number two is when you are in that phase, which is usually evoked by being on a low carbohydrate diet or through fasting, what it does, it evokes a condition called autophagy. And in autophagy, which happens when you're in that ketogenic phase, your body undergoes an internal cleansing where cells that are senescent and intracellular organelles start getting recycled. In this recycling process, your mitochondrial proteins and other amino acids also get recycled. And all redundant tissues that are sitting inside the cells also get recycled. So you basically rejuvenate in a sense. This is autophagy. It's the body's way of survival. And then when you do feed yourself, now stem cell mobilization has also been documented so that you come back a stronger, physiologically better person after having gone into a ketogenic phase as a result of the fasting. So the question is it relevant? Absolutely, but in the setting of this that I'm saying, which is intermittent fasting. So some people have taken this to the extreme and say, well, why don't I just go and buy a whole bunch of ketones and drink it, right? That has not shown, because you need a low insulin level from fasting to then get the benefit of ketogenesis. So the ketogenic diets do work, but I would advise you all that if you're going to try ketogenic diets, you need to talk to a physician or somebody who knows a lot about ketogenic diets in order to do that. I'm not advocating ketogenic diets on my patients yet, but I've done lots of research on it. The diet I'm advocating is a low carbohydrate, moderate good fat, which is saturated fat, and moderate protein diet. So the ketogenic diet is 80% fat. That's just too much fat. Why? Not because it causes atherosclerosis. No. It's just you can't hack it. You won't be able to do it. There is absolutely no doubt that simple carbohydrates and starches are simply glucose molecules stuck together in a chain. So you put 100, 200 of them together, and now you have a starch. So that is broken down to pure glucose in the body. And I'm going to say to you that that gives you a lot of glucose. But glucose is different from sugar. And everybody misunderstands and they forget that. What is sugar and what is glucose? Sugar, which is the bad boy, is 50% glucose and 50% fructose. Fructose consumption now is 5,000% more than it ever was for any of you in this room. Who's the bigger bad boy? Glucose or is it fructose? It's fructose. And who's the bad player in sugar? Is it the glucose or is it the fructose? It's the fructose. So you're talking about a starch, which is, there's no fructose in starch. So you go and you eat a yam or you eat a cassava or whatever, fully a potato. Let's just stick to a potato. Nice, simple potato. That's simple starch. Is it bad for you? The answer is no, it's glucose. It is a lot of glucose. Now, if you're overweight and you're trying to lose weight, then of course, because it'll produce an insulin response. But is it that glucose will be consumed all over your body? There'll be about 8%, 10% consumption in the brain. The rest will be in the muscles, your gut, and other parts. Fructose, on the other hand, 100% all goes to your liver. And when it goes to your liver, it doesn't know what to do with it because it does not metabolize it. So what happens to fructose? It gets metabolized into fat. The fat will be stored in the liver, giving you a nice fatty liver. And then the rest will be exported to your belly, giving you the belly fat. So the simple answer is, if you have a weight problem, then yeah, starches are probably to be avoided. If you don't have a weight problem, it's not too bad. Starches, I don't have a problem with starch. Generally speaking, I keep my starch intake low because I just don't want to gain too much weight. But it's the sugar that's the real problem. And then complex carbs, fantastic. I have no problem. There's sugar in those too, but they come with fiber. They come with fiber, which decreases the rate of absorption of your glucose. So understand that, yes, some people will say avoid all the starches completely. It depends on who you are. But the starches are not your biggest problem. The biggest problem is sugar. It's sugar. And 86% of anything that you buy in a supermarket will have sugar in it. So, my short answer, it's a long answer, but don't stay away from starches. If you like a potato, have it. If you like a root, beetroot or whatever, anything, have it. There's no problem with it. And remember, it's the way it came out of the ground. It looks like that, have it. But sugar didn't come out of the ground like that. You forget, sugar is processed. It's like those vegetable oils. It's processed. If you went to a sugar plantation, a sugar plant would actually make the sugar crystals, you will not consume sugar anymore. So I'll take the salmon part first. So I do like salmon. I think if it has a lot of omega-3 in it, that's fine, and it's a good source of protein. Again, there's studies to show that fish also induces hyperinsulinemia. So if you're already a diabetic and your insulin levels are running high, fish will actually, and chicken, both stimulate insulin production. So if you have a problem with insulin resistance, and you'll know whether you have insulin resistance or not because you have the belly that's big or you have blood tests, so if you're a diabetic, you should only eat fish once or twice a week, no more than twice a week. Secondly, it has mercury in it. So I know that some of the salmon is well caught, and that's probably okay, but no more than twice a week. And so really, I have no... one more thing. Communities that consume fish just about every day have a high incidence of cancer of the stomach and GI problems. So again, you don't want to do too much of fish. You don't want to, no more than twice a week. That's it. Small portions of salmon are fine. So I have no issues with that. The next question was about the grains. Oh, actually, that's the last one. I'll just answer the grains question. No, I don't like grains in general. Grains, I think that fatten people. That's what cows eat, and they become fat. And I think they have a lot of lectins in them, make you gain a lot of weight. It causes insulin resistance. It makes people definitely overweight. And I think the agricultural revolution is clearly evidence that the increased the intake of grain made people shorter, smaller, sicker in many ways. I don't think look, grains were made to make you survive through the winter. It's a survival food. Bread is a survival food. It's become a day-to-day food. It's a survival food. That's what bread really is. So we should cut down on grains as much as possible. Cereals should be avoided completely. Completely. I don't think that cereals should be given to kids. It's extremely high in sugar, and it causes insulin resistance, and it will cause very high spikes in your insulin as well as your glucose. So all cereals, breakfast cereals, should be banned from your children. And then you asked me about MCT. MCT is an oil that's found, is a type of oil, medium chain triglycerides. It's found in coconut oil. I like MCT oil. I like coconut oil. It's saturated oil. It's not polyunsaturated, so it can't interact, doesn't oxidize other structures in the body. MCT itself, the higher concentration of it, makes a transition to the ketogenesis easier. So if you have more MCTs in your body, because you're on a diet that eats more coconut, you'll more easily go into some ketogenesis if you don't eat. So people sometimes who are fasting, they will put coconut oil in their black tea or something, they call it bullet coffee, to induce faster and easier ketogenesis. But yes, I don't have any problems with coconut oil. Coconut oil is excellent. I have no problem with it. What about meat? So we just showed some slides to show that meat has not been correlated in any study to be of increased risk. Okay, so the question is that what should we do with meat? Very tough question. And as we do all this research, sometimes you get really confused. Meat has been associated with heart disease in some studies. And what it is that it's not so much the fat that's in the meat, the saturated fats, but what happens is that the meat contains endotoxins, and depends on where you source your meat. If those endotoxins are in the meat, through saturated fat that's in the meat, it gets into your bloodstream. And when it gets into your bloodstream, it causes inflammation. So meat can be inflammatory if it has a lot of endotoxins in it. So that study came out, and that really bothered me. And I said that, my goodness, we shouldn't be eating meat because it's got all these endotoxins in it. But it depends also on the source of the meat. The second thing about the meat is today's meat contains a lot of omega-6 in it, because as I said before, they're all eating corn. Those cows are eating corn. They're not eating grass. So it's excessive amount of omega-6, and omega-6 is pro-inflammatory as well. So that's point number 2. Point number 3 is that the animal protein, particularly in beef, produces a thing called TMA in the gut. So what happens, the bacteria attack the protein of meat and then produce TMA. TMA then gets absorbed into the body and gets oxidized in the liver to TMAO, and that is inflammatory. And that's been also documented. So overall, there are studies to show that meat consumption is inflammatory. There is. So my advice to people in general today is, look, if you cannot, look, you know how hard it is to tell people to become vegetarians? It's extremely difficult to do that. But if you can hack it, eat as little meat as possible. But most people can't do that because they've been doing this for 50 years. So I tell them, okay, fine, you can still have your meat, but source it right. Make sure that you're not eating red meat more than twice a week, and make sure your portions are small, and make sure it's grass finished so that there's more omega-3 in it and less omega-6 in it. And source it right, because endotoxin is going to be in it, and endotoxin does get into the bloodstream. And it's, by the way, endotoxin is what is carried also by the LDL molecules. That's why people who eat too much meat, they get small, dense LDL, because the LDL, in order to carry that endotoxin, knocks off the cholesterol, so the LDL particles become smaller. So they get smaller, dense LDL particles. That's also been documented. So look, when I first started this out, I was very much in favor of vegetarianism. The more I read about all this physiology, I realize that it's not so much the meat, it's also where the meat comes from, what the cow ate, endotoxins. So I'm not totally opposed to it right now. So I'll allow some meat intake, but it should be limited. It should be limited. Absolutely true. Absolutely 100% true. There are a lot of patients who come into my office, they have a mental fog, and gradually they just kind of deteriorate. The cognitive function, everything is bad, and I give them a statin holiday, and all of a sudden they say, Doc, I feel so much better. I'm able to think better, my mental fog is gone, I feel so much better. The brain is composed of cholesterol. We need cholesterol in the brain. Absolutely 100% true. So you got to be careful. That's why, fine. If you had a heart attack, I will put you on a statin for maybe 6 months, maybe a year. But once the fire is out, and I'll explain what I mean by that. Your CRP is down, your HDL is better, your triglycerides are better, you are looking better, your fire has gone up because your inflammation's gone down, I'll stop that statin. Because you need to, because in the long term, it will catch up with you and it'll imperceptibly do it. So, and it may reduce your future risk of heart attack. I don't disagree with that, but that risk is only this much, but your overall mortality will not change. So you'll die of something else. And I already told you, the NNH is the number needed to harm, is fairly high. So you've got to be careful about that. Well, first and foremost, we do know that patients who have familial hyperlipidemia are at increased risk of having cardiovascular disease. But that's if you lump them all together. The risk is there. But again, it's a small increased risk. And when you tease it down, we're finding that these patients who do get heart disease with familial hyperlipidemia, a lot of them have the same numbers and they don't get heart disease. So what is it for those who actually did get the heart disease? We find that they have increased clotting factors. So their factor VIII levels are high and their fibrinogen levels are high. So they tend to make blood clots. So that subgroup of people who have familial hyperlipidemia are at increased risk. So what is our current advice? If you go to a lipidologist, they'll all say you need to be on a statin. And they will also most likely add a PCSK9 agent because that's where the current knowledge is. But there are a lot of practitioners who will say, you have familial hyperlipidemia? Okay, let me see if it has already hurt you. They'll do a CT scan of your heart. If you have no calcium, well, excuse me, you had a high cholesterol level, right? Familial hyperlipidemia, and there's no buildup of plaque. You are not one of those that's going to have a problem, and they leave you all alone. And then they'll tell you, come back every 2 years and do a calcium scoring study of your heart. Now, do you all know what a calcium scoring study is? It's a simple low-level CT scan of your heart with no contrast injected. You simply do a CT scan. If there's no calcium in your arteries of your heart, you have no plaque. So by doing a CT scan of the chest, you can tell who's getting disease and who's not. So let's say we did a CT scan on somebody with familial hyperlipidemia and it's 0 score. I can be comforted. And as far as dietary interventions, none has been proven in those patients to be of any significant benefit. But I'm telling you, it's still sugar because sugar has its own pathway. So still cut out sugars, do all the good things that I've been saying all along. Not because of the cholesterol, but because it can also cause coronary disease. But doing a CT scan is very helpful to tell you whether you... Now, let's say your calcium score comes back positive. Calcium score is 400, and you have familial hyperlipidemia. What am I going to do? Well, would I put you on a statin? I might put you on a statin. But I'll also look at your CRP levels to see if there's inflammation in your body. And I'm going to look at insulin, because what's stopping a familial hyperlipidemia patient from also having insulin resistance? Do you see what I'm saying? So you've got to look at the more broad picture. As far as hyperlipidemia itself is concerned, familial, the jury is out. All the experts disagree. Half of them will say, yes, put on a statin and plus a PCSK9, and the others will say no. So I think that my approach to that is to look at the broader picture. What is your HDL and triglycerides? I'm going to look at those ratios. I'm going to look at your insulin levels. I'm going to look at your weight. I'm going to look at your diet and lifestyle. I'm going to look at your sleep patterns. I'm going to look at other things. I think we need to be more broader than simply looking at that. Otherwise, once again, if you become just tunnel vision onto the familial hyperlipidemia, you'll forget that you have an enemy that you ignored, and then you succumb to a heart attack. I like beans. Beans do have a lot of carbohydrates in them, but beans also come with a lot of protein in them and a lot of fiber. So I have no problem. But if I have a problem, let's say that I've done everything. I've stayed away from sugars. I'm doing everything, and my sugar levels are still high. And the only bad thing that I think I'm eating is beans, then I'll cut back on beans. But in and of themselves, you're not going to get that much bang for the buck by cutting out on beans if you're still consuming other sources of glucose, which is found in complex carbs. So beans are not bad. But yes, if you eat a lot of beans, you're going to gain weight. Because beans have calories in them. There are a lot of calories in them. Because ultimately, that's the seed that's going to fuel the growth of that plant as the cotyledons as they grow out. That's the bean. And then the inner shoot that comes out until the roots start giving it a supply of nutrients. So yeah, excessive beans will definitely make you gain weight. There's absolutely no doubt about it. Beans will make you gain weight because they have a lot of sugar in them. They have a lot of starch in them. So just back off on beans if you have a high sugar or if you have a weight problem. Beans. And remember, beans also need to be cooked properly because they have a lot of lectins in them. So you need to kill those lectins. So you need to soak those beans first to kill the lectins in them. Because if you don't, you will get indigestion and gut problems.